Okay, complications. Now, here's the worst thing about complications. If we're not expecting them. If they happen and you really did not expect them to happen, that's one thing. If they happen and you don't know how to handle them, that's another matter. Okay? So be ready. So some complications can happen intraoperatively, postoperatively, early or late. Okay? So what can happen intraoperatively? Bleeding, yes, we can handle that. Membrane perforation, of course, we can handle that. Pathology. Now, if there is pathology, is it sinus thickening? Is it a polyp? Or is it a cyst? Or is it a full sinus? But intraoperatively, if it's membrane thickening, we're not worried about it. If it's a small polyp or if it's even a small cyst, that's all okay. We're going to cut the membrane, get it, and take it out. Send it to pathology, but we're going to take it out. We're not going to abort any procedure. Osteomeatal complex. Is it obstructed? If it's obstructed intraoperatively because of something I did, I won't know about it right away, right? But I must make sure that it's clear and patent before I start my surgery. Okay, I want to make sure that the ostium is clear. I can see this black communication between the top of the sinus and the infundibulum. Alveolar ridge fracture. This is not very common, but in some cases, I can, I do ridge expansion and a sinus lift at the same time. Okay, I haven't had that happen, but I'm very careful. I'm looking at the bone, making sure it's not splitting as I'm working. Damage to adjacent dentition, that's very rare. I mean, you have to be overly aggressive and really doing it on purpose. Okay. The one thing that I think is more common than the damage to dentition and alveolar ridge fracture is the inadequate graft fill. Okay. So I'd say bleeding and membrane, I'd say membrane perforation, number one. Bleeding, maybe. I had it happen once. Okay. Inadequate graft fill, that's also very common. Pathology, septum. Now, if you get a septum in the bone, are you going to do 2 windows or 1 window or 1 window over the septum? How are you going to handle it? And then are you going to leave that piece of bone there or not? Okay. You can trim it and you can take that bone and make it part of your graft. Okay. And the part that's coming up, you can actually use your round burr and you can flatten it and you can make it nice and nice and smooth. Okay. Sometimes if the septum is in the right spot, it can actually be my implant insertion point because that's an area where there's a lot of bone. So I can actually, and I'll actually do like a little crestal lift while I'm doing the lateral through that area too. Okay. So a septum is not always a complication. If it's in the right spot and if you know how to deal with it, you can always use the septum to your advantage. Thank you very much. May we get some orange juice, please? Yes. Thank you. Okay. All right. I've talked about this the posterior superior alveolar artery. We talked about the inferior alveolar artery. We talked about their anastomoses, and we talked about their branches intraosseously and extraosseously. Talked about the sphenopalatine artery and the posterior palatal septal artery. All these. There's a lot of blood. It can happen. How do you handle it? Okay. How do you handle it? Elman. Here's the unit, okay? And I'll show you where you buy it, not for $9,000 or $10,000, but for probably less than $3,000. It's a good investment, okay? You never know, but when you need it, you really need it, okay? And it's radiosurgery, it's not electrosurgery, and it will actually not cause heat, and it's a very useful tool to have. Membrane perforation. Prior to coming to the to the lecture, honestly, how many of you had that on their mind, that the membrane perforation is the number one issue to handle, to deal with? Right? Now, are you worried about it? Do you feel more assured about handling a perforation? I bet you're thinking, how am I going to get the membrane to stick? You're not thinking about the perforation now. You're thinking about how to handle the membrane and the sinus, okay? But if you get a perforation, that's okay. We know how to handle that. We're going to put the collagen cross-linked membrane. Thank you, thank you, thank you. So, yes.
So what about the size of the tip?
Doesn't matter.
Is it, I mean, can the tear go like?
You can have
bigger than
total
the other?
tear.
Okay.
You can have total
So the
tear.
membrane, how will you get that membrane to cover? It's not big enough to.
Yes, it is.
The bone gonna
It's
stay
30 by
there?
4.
Okay.
We're not using the membrane 30 by 40. We're not using the membrane. So we're not using the membrane to cover a hole. We're not using the collagen membrane to cover a hole in the Schneiderian membrane. We're using the collagen membrane because that's going to be our roof, our ceiling, in every single case, as if there is no membrane above it, no Schneiderian membrane above it. Okay, that's why the 30 by 40 is quite substantial. Okay, it's substantial. It's a big piece, and if your window's bigger, use 2. Suture them together, trim them, use 2. Okay, but you're going to have that membrane secured to the outside and going all the way to the posterior wall. No bone is going to go past it. And if the bone you made using, see, if you made sticky bone, the chances of that bone traversing the sinus cavity is even decreased further. Okay? So we're not using the membrane to cover a hole. We're using the membrane because that's our ceiling, that's our roof. We are setting the rules. We are setting the parameters. We're not letting the Schneiderian membrane dictate our sinus lift. We are going to place something there, and we're placing the bone no matter what. You look at me like it's confusing.
I think if I continue it at the bottom with the floor. So the membrane we put on the bottom. And do the like, so how can you make sure the bone not get into
The sinus.
It's the bone.
Let's say you have a big tear of the membrane. Okay, look here. Look at that tear. Upper right photo. Okay, so we are making our own ceiling. We're not allowing, we're not counting on the Schneiderian membrane to protect the bone graft we're placing.
To all the membrane on
Yes.
the floor and put it on the top and then we.
Yes,
That's it.
yes.
So, like, yeah, then we put the-
Yes. So no Schneiderian membrane on the sinus floor, no Schneiderian membrane on the mesial or distal, no, and we're pushing it back, and we're pushing it on the back, the posterior wall, we're pushing it up a little, and then we're putting our membrane. Whether we have partial tear, total tear, small tear, big tear, we're putting the membrane. Okay? So we're not, our surgery is not being dictated by the membrane. Cool? Okay. And there's no reason why we should abort because the membrane got torn. Okay. Again, these are photos. I'm repeating the photos of placing the membrane and putting the tags to hold the membrane in place. And look at this, Dr. Tu. Look at this cross-sectional view. Okay.
So we assume like, no ball gonna get these.
Yes. Not assume, we're going to put the membrane in a manner that's going to hold everything in place.
And this would prevent the bone from going to the opening of the.
Yes, the osteo. Yes.
Have you ever had a hard time separate the hair membrane from the floor? Like
Yes.
When we tear and then you feel hard time, you know.
Sometimes, yes, it's like it's stuck and you're like scraping it off.
Yeah, you cannot like lift it, you know, it's gonna keep tearing or something.
That's fine. Then I'm just removing it. But I never had it to where it was that resistant. Once I get it off, you know, it pretty much follows. But sometimes it tears and for no reason. Sometimes you're just lifting it and then you find "Whoop." Now. Are we okay?
Can I add something here?
Yes.
I've asked ENT physician about tearing the membrane. And he looked at me like, so what? He's like, we tear it all the time, and they go into the water and sinus,
Yeah.
they clean the sinus, it tears all the time. So as a dentist, I think we're a lot more scared of tearing it.
Yeah.
because it's not what we learn in school,
Yeah.
but they tear it all the time.
Yeah. And nothing happens.
And also, I spoke to him, he said that, you know, when he plays signal, sometimes he's just perfect, he just don't go right through it. You know, when he goes through it, he said that, you know, it's be fine, it'll heal, it's very,
Yes. Yes.
As long as you get the fix for, you know, the implant not moving.
Yeah.
it's fine.
Remember the study I shared? If you perf and graftless, it heals and the sinus doesn't get infected. For some reason, somebody put the fear of God, like we're so terrified. I don't know why. It's a space.
If you don't do it.
Yeah.
Often you're afraid, because they don't teach you in school.
That's
They want
true.
you to do it. They want you
Teach
to
you
do
to
it.
be afraid. Doctor, just make it clear, so you put the membrane on the superior
Yes.
and posterior, and
Yes.
then inside the para.
Yes. Let me show you here.
So we're like pulsing the graft.
So the PRF is right here.
Here.
You just take the PRF and you kind of, it's like wet Kleenex and you're throwing it against the wall, against the back wall. Does that help? You know,
I think it's
like
like three-dimensional, she has a hard time visualizing.
this is the lateral
Yeah,
wall
it's
here.
lateral wall.
So we're pushing, we're accessing from here, right? So you're just putting the PRF along where the membrane and the bone meet, the collagen membrane.
Yeah.
And the bone meet, that's where you're just laying it there. It doesn't have to be like 50% on the membrane. You're just throwing it against that wall and that's it.
But your
Nothing
collagen-
fancy.
But your collagen membrane is just one.
This is the collagen membrane. This is it. That's the main play. No PRF, no problem. Okay, no PRF, no problem. No membrane, big problem.
Okay.
Okay. What are we talking about here? Membrane complications. No, we're talking about pathology. Okay. So if there's a cyst, if there's anything in the inside the sinus, we're going to open the membrane, we're going to grab it, and we're going to take it out. Is that going to cause a tear in the membrane? Yes, we are doing it on purpose. Okay. Do we care? No. Okay. Sometimes you do internal tag fixation, but let's not complicate matters. If you do the outside ones, that's perfect. Okay. How's that, Dr. Two? Is that a big tear? Now, back in the old days, I would abort and wait for the membrane to reepithelialize. And then you go back in and tear it again. Exactly. You wait 6 months. 6 months. How much thicker you think the membrane's gonna get? It's still 0.3, 0.6. So it's an exercise in futility to wait for this guy to, to behave. So we're gonna do without its cooperation. Okay. Okay. In the complications, we were talking about bleeding, membrane perforation, and now we're talking about pathology. Okay. So this is an interesting study. They had dentists and they had ENTs, and they had them, look at pathology and look at membranes and look at CBCTs and look at retroactive studies. Okay. And here's this. Okay. How are we going to manage the sinus if we have thickening? Okay. Just thickening. Basal flat, like if there's the top photo, no alteration. This looks like a normal membrane. The one on the bottom looks like there's a basal flat thickening right here. Okay. When there's basal flat thickening, what's happening? The ostium patency prior and after sinus floor elevation is mandatory. So we want to make sure that the ostium pre-surgery and post-surgery is nice and clear, that the patient can possibly lower risk of membrane perforation. The one on the bottom here, because it's a thicker membrane, possibly lower risk of membrane perforation. And I actually want to change this language. I want to take out the word risk, because now it's an event, it's going to happen. Okay. So I don't want to think of it as risk. I want to think of it as something, as part and parcel of what we do. Okay. Now look at the top one here. You see this? Dome shaped. Okay. What do we do? Fluid aspiration may facilitate sinus floor elevation. So sometimes they want to aspirate the fluid in the thing. I say no. I say take the whole thing out. Now you got bigger. You got a bigger one, okay? Decision about referral based on membrane thickening, not on calcification. Some authors recommend referral to ENT in any case. So if you see something that's exceeding 1/3 of the sinus thickening, refer to an ENT, which might be prudent to do initially, okay? On the bottom here, circumferential thickening. You see the bottom one? All the membrane is thick. This has high risk for post-operative ostium obstruction. And why?
It has thickening on the bottom and on the top as well.
Yeah. what's gonna happen here after if we were to do a sinus floor elevation, if we were to do it? It's, it's gonna swell up, okay? So this may actually obstruct the ostium more, okay? So this is a case that looks like maybe some kind of chronic sinusitis that we want to not handle, but maybe send to an ENT to, and then let's take a look at it after 4 months and see if the ostium is more patent and that swelling has gone down. Okay. Now, anything that looks like this that I didn't cause, okay, they're going to their doctor. Okay. Anything that looks like the bottom there just looks like a malignant lesion. All right. So remember, not every case is for us. Not every case is for you. Some cases I say, "Oh, I'm not gonna do it. I don't need it." So you assess using the CT, and these are the things we want to notice. Do we have thickened sinus membrane? Do we have polyps? Okay, or do we have the mucus retention cysts? Mucus retention cysts are slightly larger than the polyps. Okay, in both cases, it's safe if you open the sinus and you take it out, you send it to pathology just to rule things out. You can start them on antibiotic before, after decongestants, and the whole 9 yards, like we outlined. Thickened sinus membrane, no problem. Okay, if the thickening is all over, watch out. You may cause the ostium to be compromised, and we don't want that. Okay, easy, makes sense. You know where to draw the line. You know where to draw the line. Okay. Okay, Dr. Desai, tell me the 3 situations where you would still do a sinus lift.
Patients smoking less than 10 cigarettes a day.
No, with regards to pathology.
All of this, um,
Membrane,
memory rupture.
thickening.
But I get confused with chronic sinusitis because in the beginning you said we can still do with chronic cases, but not with the acute cases, right?
Yes,
So, but in the last few slides, you mentioned that that's the cases of chronic sinusitis, so we shouldn't doing it, rather than we should send to the specialist.
no. Look here. This last photo right here.
Mhm.
The thickening of the membrane is all over. There is higher risk of closing the ostium
Mhm.
after sinus floor elevation. So you can certainly treat them if they've suffered from chronic sinusitis,
Mhm.
but not while it's active.
Mhm.
It doesn't preclude them
Mhm.
from getting the surgery done. Okay? But in this case, where the thickening is all over the sinus, once you do the lift, it's going to. But look at the one above. Look at another one above where it has the basal, like this one right here. Okay, or this one. There's thickening. Okay, thickening, polyp.
Mhm.
Okay, or a mucus retention cyst. Okay, they're localized. You can access to the window, take the pathology out, and you're fine. Okay, acute, no. I'm jumping through. Okay, here's a look at this one. Very thickened, okay? And you can actually run a risk of obstructing the OMC, okay? Do the same. Polyps, same. You see the polyps right here? okay? And you open the sinus, you take them out, put the membrane, you graft, you continue, everything is fine. Sometimes you get those tissues in the membrane, take it out, clean it out, membrane, and close, graft, leave, and then come back, okay?
The doctor, you should always have the, you know, you collect the sample, you should always have it just in case.
Yes, and actually, if you contact any lab near you, Quest Lab or whatever, they'll set you up with something, so it's fairly easy. Or you can call them and, you know, a day in advance, it's like, hey, you know you have a patient that's coming for that, so you say, hey, if I want to do this, what's your procedure? What do you give me? Can you give me a couple that I can keep in a fridge? And then what information do you want me to put on? How much do you charge me to get me a histological workup and all that? Okay. Okay, polyp is the same. Here it is, you see it. I mean, it's a cyst, mucus retention cyst. You open, see it's coming out. And you put your membrane with the bone graft, close it, everything will work out. Okay. So this is part of the complication. Okay. We are not afraid if we know what to do. We already count on the fact that the membrane is going to be torn, and we know what we're going to do. And we have our armamentarium if we face a bleed, okay? Conclusion, what to do? If it's thickened membrane, we elevate it and we proceed, okay? In general, pathology removal with simultaneous grafting is recommended, Dr. Michael Picos, okay? The Picos sinus membrane repair technique, he coined that many, many years ago. He's been doing this since 1989. And he shows years and years and years of his technique working. So septum. Like I said, when you get a septum, you either have to do 2 separate windows, or you do 1 big window and then you elevate the membrane, expect there will be a tear, okay? And then you cut the septum down. You can take the extra piece of bone, you can grind it, include it in your bone graft, okay? And you can actually trim the rest, put the implant. If the septum is wide, has a wide base, and it's in an area where a tooth can go, you can actually use the septum to place an implant. So it might be a good complication, quote unquote, to have. Okay. Osteomeatal complex obstruction. This is one that we must be very, very aware of. Excuse me. So you bring them back a week after surgery. If you can do a quick CT, that would be great. Yeah, but doc, what about radiation? Okay. People may raise that. With the machines that we have now, if you spend an hour traveling in the air with Spirit Airlines, you get a lot more radiation than what you do in a CT. Okay. As a matter of fact, if you go to the beach and you sit out there for a couple of hours, you've gotten enough radiation. I mean, with the amount of radiation coming out of the machines right now is so much less. Now again, the old adage, okay? No amount of radiation is safe, but believe me, we're being irradiated daily, okay? Think of airline pilots. They still fly planes, and they do it for 30 years, and they're getting zapped all along. You know, the whole time they're getting zapped. Okay, alveolar ridge fracture. I don't see that a lot. If it fractures because you didn't calculate well, you didn't look well, you didn't measure well, you were too rough, you know, bent your hand with the tool. I don't think, and the same thing with dentition. Okay. Okay, so these are the complications intraoperatively. Bleeding, we're not afraid of. Abdomen unit, membrane perforation, we count on it almost all the time. Pathology, we remove it. If it's thickening of the membrane, if it's a polyp, if it's a mucus retention cyst, okay? Anything more than that, where half the sinus can get affected, we're gonna make sure that that it's cleared before we take it out. Osteomeatal complex obstruction, that's a possibility. We want to bring them back and take another CT and make sure that it's nice and clear, okay? The rest, alveolar ridge fracture, very rare. Damage to adjacent teeth, very rare. Inadequate graft fill, I think this is one of the most common ones. This is an exaggerated view right there, but it hasn't been well packed. And there was a perforation. I mean, I think there was a perforation in this case. I don't think you get some particles of bone flying up like that. That's not normal. Okay. So in order to avoid inadequate fill, make sure your membrane on the mesial, okay, and on the floor, not only on the floor, but go all the way to the posterior wall, lift it up, and then put the collagen membrane. Okay. Post-operative. Okay. Very soon here, I'm going to get to a decision tree where you're going to decide, what if, then do this, then do that. Okay. So I'm going to walk through this very fast. Post-operative, early, incision line opening. Okay. What do we do? What did we do? We did not release well. Okay. Our sutures were lacking. Bleeding, acute infection, graft loss, partial or complete, implant migration, I've seen that, implant failure, I've seen that, barrier membrane exposure, I haven't seen that yet. Okay. Post-operative, incision line opening, okay? You didn't release well, okay? You used only chromic gut suture and you didn't use sutures that are going to last for a good 3-4 weeks. You want something solid. You didn't tie your sutures well, but you didn't release enough, okay? Bleeding, it happens, okay? And you get, but I do warn my patients, say, you're gonna bruise a lot. It's gonna start up here, and it's gonna come down, it's going to migrate, and it will look like you had a fight. And if you're, I try to make a joke of it. If there's a husband or there, it's like, try not to go out with her that, when she's like that, because they'll call the cops on you. At least when I do that so that they remember, just so that I remember. I'm not trying to be, rude or anything, but I just want them to remember so that when it happens, they're not calling me and freaking out. I want them to know that I warned them about it. Okay. Acute infection. I've had that happen, honestly, in 12, 13 years, I've had that happen once. Acute infection in a sinus lift. And it happened on the 4th of July. And I was in Michigan, and the patient called me from here. And the very next day, I was on the plane coming back to see the patient. So I do remember when I had the acute infection. It's not very common, okay? And if you follow all the procedures, if you give them all the drugs, and if they're not lying to you, okay, then it should be a very rare occurrence, okay? So it does happen though. You are going to see it. Now, when an acute infection happens, what do we want to do? We want to give them antibiotics, and we're going through the decision tree. and we want to wait 48 hours. Did they improve? Yes. Proceed? No. Then what are we going to do? And that's the whole purpose of complications, not just naming the complications, but managing the complications. Okay. So what's going to happen? You're going to swell. We all know that. The ecchymosis, the discomfort, the pain, maybe nosebleed. Okay. It usually disappears within a couple of weeks. Okay. A week to two, everything is resolved. Okay. I'm going to cut this picture into half, and then I'm going to blow it up and have it in another slide. Okay. Here. Early post-op sinus graft infection. Okay. What are we going to do? We're going to change the antibiotics. I usually start them off with Z-Pak, and I want them to stay on Z-Pak. And I don't start with the nuclear option right away. I just do Z-Pak. If on the fourth day they call me, it's like it's getting hot, it's swollen, and they show me a picture and their eyes getting swollen here, and bad taste and bad odor coming out, and they can't smell out of one side of their, I immediately go nuclear. I go with Augmentin and Flagyl, and we'll give them ibuprofen and Tylenol, and I will even the nasal decongestants I've been giving them already. Okay, but I'll go nuclear with but I'll give them a mouthwash as well. Okay, and I don't. Flagyl, yeah. Okay. If after I switch the antibiotics within 48 hours, things quiet down, I don't do anything. If things do not improve, then I bring them back and I do a re-entry. I numb them really well. Okay. Now remember, they're agitated, they're in pain. Giving them the injection is not going to be like the day of surgery. It's going to hurt a little more. They're already tired. So at that point, I'm not opposed to giving them Valium ahead of time. Okay. I just want to take the edge off, and I want them to be a little more relaxed in the chair. Give them antibiotics, give them the injection, and then open the site. And it's easy. I mean, and when you open the site, don't open a new incision. Use your same old incision. Don't open a new incision. Use your very same incision. Okay. Cut, wash. I usually wash a lot with antibiotics, and then I'll take the graft out. Okay. If there is pus, just take everything out. Okay. And lavage and clean it out. That guy I flew back for, I took the implant out and there was green stuff coming out. It was just green. And I had the suction, the high-speed suction. It was just like for like a minute or so, and under the, I mean, this guy got it really bad. Cleaned everything up, changed the antibiotics, and he healed okay, but I will never forget how an acute infection in the sinus looks, feels, or smells like. Oh, some bacteria went in and took hold. And was it in the office? Was it there to begin with? Okay, did his immune system take a dip and those bacteria took over? So we treat this empirically. Okay, we give them antibiotics and then okay. Treatment protocol, clinical evaluation, radiographic, do the CBCT. You give them the antibiotic coverage. You reevaluate in 48 hours. If no improvement, then you follow up with them every week. If no improvement, then you do re-entry. After the re-entry, you follow up every 5 to 7 days, okay? If there's any fistula, if any, the flap is dehiscence, if any purulent discharge is the one that I look at with the most with the most concern, okay? A patient came, you know, like that. Do you say, let me give you antibiotics and you're gonna be better? Okay, get everything out, because that stuff can migrate and close the osteum easily, okay? I get every particle I put in out, okay? Wash them really well. Antibiotics, close the site really, really well, okay? And keep a very, very close eye on them. I'm giving them a call every 2 days or text, okay? Okay. And the antibiotics we're giving, we're doing this empirically. You can take a culture, send it to the lab, come back. You are still going to use the same antibiotics. Haemophilus influenza and Streptococcus pneumoniae and Moraxella catarrhalis. These are the 3 that are usually prevalent in an infection like that. Okay. And this is how we're going to treat them. This is the 3rd time that I put this slide. Okay. Augmentin and flagyl. Or you can do levofloxacin. Now, look at this. Ceftin, if somebody has penicillin sensitivity, you can use the Ceftin, okay? 500 milligrams twice a day times 10 days. Now, if they have real penicillin allergy, like type 4 hypersensitivity, they take penicillin or anything related to it, and they turn blue and they can't breathe, then you can give them levofloxacin or Levaquin. Okay, so there is a little bit of cross allergenicity between penicillin and Ceftin and Ventin. You know the difference. So some people have a true allergy to penicillin. They take it and they go into type 4. They can't breathe, turn blue, okay? You don't give Ceftin or Ventin. But if you give them Levaquin, okay? And but if they don't have true allergy for sure, okay, you can give them Ceftin or Ventin. I don't play around. I give them the Augmentin. If they're allergic, I give them the Levaquin, okay? I rarely use the other 2. And I'll tell you another tip. You get somebody and you're really concerned about them. I call this pharmacist, you know, I say, hey, I got this patient who's really resistant to, and he's got this sinus. What do you think works best? If they answer me, fine. If they don't want to answer, I'll find somebody that'll answer. But they're usually very happy to, to give you an or tell you or recommend something to you. If you know an ENT doctor, call them, say, hey, I got this patient. I've given them so and so and so. You know, it's been a week and the signs are not going away. The symptoms are not going away the way I want them to. What do you recommend to give the patient? Okay. But usually what we have here in the slide works. Okay. If there's improvement, leave. If no improvement, re-entry. Re-entry, you open the flap, same incision line, okay? Take everything out, clean it up, okay? And then and then what are you going to do? Do you regraft or do you let them heal? If you clean everything out, you can actually if it's not the whole thing, okay, you can complete the graft and close. But if it's a huge infection, take everything out and then close. Okay, with a window. All right, this is what you're gonna tell them. Don't blow your nose. Okay, don't drink liquid through a straw. Take your medication. You may have some small granules coming out. Here's my number. Call me. All that stuff.
You still putting collagen in after you take everything out?
I'm putting collagen out on the outside,
out-
just on the outside, because I'm going in later on.
You move the inside one and it's still torn. You put another one there or just close it on the outside?
I'm removing everything.
If the membrane is still torn, you put another collagen inside or not?
Oh, next time,
When they come in for infection?
or they come in for an infection, if it's torn, no, I'm not putting anything. But we're cleaning everything out. Because something is causing this reaction. So and the antibiotics, they didn't heal within it, there was no resolution within 48 hours. So whatever foreign that is there is coming out. And we're keeping the antibiotics and we're saying, okay, no offending factors now. Let's see. Okay, because it's a variable that we have to do away with. Okay. Implant failure, cyst, or intraoral communication that may happen. It happens. We actually are seeing a case either tomorrow or Sunday, a case that we did. One of the implants made it, the other two for some reason didn't. I think I know why. What are we doing? Okay. So we're going to give the patient antibiotics. After 48 hours, reevaluate. If it's good, proceed. If it's not good, we're going to do re-entry. When we do the re-entry, we remove part of the graft or all of the graft. Okay, and we close, and then we go back in again. Okay, here. The two slides on top of each other. Of course, you must do radiographic evaluation. You must do a CBCT so you can see everything. Okay. Here's that slide again, antibiotic coverage. Okay. You're doing the re-entry. I'm repeating over and over and over again. Okay. So patient comes in. I have this. You give them antibiotics, giving them augmentin, we're giving them flagyl. And in 2 days, we call them, things are not resolving, come back in, we take a CT, we look at it, is the ostium open? Have things moved around? We look in the mouth, same incision, take it out. I'm usually rinsing a lot with antibiotics, taking everything out, rinsing more with antibiotics, taking everything out, rinsing all with antibiotics, put the membrane on the outside, close, stay on the antibiotics, bring him back 6 to 8 weeks, and then do a CT, make sure that the sign, like the ostium is still open. At this time, you may not see a sinus everywhere. Okay, just make sure the ostium is good. Proceed. Okay. Take everything out, clean it up. Okay. And sometimes you get voids. Sometimes you get voids like that. Frankly, what I would do here is I would use the Versa technique and just add more bone and just condense more bone in the area and place the implant. Okay. And this is just more photos showing you the same thing again, opening it up, doing the CT, putting the membrane, putting the bone, closing, and all that. Okay. Let's go to another complication here. The barrier membrane exposure. You see this area of exposure. Okay. We're going to treat this by doing 3 things at once. Okay. Because this is almost an oroantral fistula, right? Almost. We don't want it there because all the bacteria is going to get through it, go into the sinus, into the graft. If not now, later. Okay. So Implant failure, we open it up, we take it out. Okay, here's this right there. What are we going to do? We're going to do three things. Number one, we're going to open it up. Okay, we're going to suture that tissue it's open. We have a circle of discontinued epithelium, right? We're going to suture it together. Okay, if you can take a piece of connective tissue graft and put it there to close it, go ahead and do it. And then we're going to do collagen membrane over the bony area. Here we are. Here's the exposure. We sutured that opening, that hole, we sutured it. You can put a piece of connective tissue graft. You can see how thin this is. And then you put a membrane underneath it and it will resolve itself and it will be just fine. This way you don't have any more communication. If you don't want to open the patient's palate and take a piece of connective tissue graft, you can buy it from Geistlich. Okay, they sell membranes. You can take them and you can stick it underneath. Okay. All right, so although sinus graft infections are not common, they are not common, yet they must be treated early and aggressively, okay? Pre-operative CT evaluation protocol is a must. Strict case selection is an imperative. Somebody who's got conditions that we deem as contraindication or severe chronic sinusitis, we don't want to be doing their cases, okay? Now, here's a very pertinent topic, crestal approach complications. In most cases, we may not be able to detect or see the crestal tear, okay? So if there's a crestal tear, it's a blind procedure. You may not be able to see it. And what are you going to do? It can be a small one, can be a large one. It can be one that you will not know about caused by your implant going in. Okay, so a small one is like this. Large one is like figure C. D is where you get you put the bone, and one is where you put the implant, but there's a tear beyond those. Here they are. Here they are. Intact, small, large. What do you do? Okay. What's our approach here? So, do we have enough crestal bone to place a short implant? If we have an 8mm high ridge, maybe I can place a 5x6. I'll throw in a PRF in there, and I'll throw in a short implant and call it a day. Okay. If not, then I can open a lateral approach and put a membrane in there. Okay. Here's what you don't want. You don't want any bone flying in the sinus. Okay. You don't want any particles roaming free in the sinus. Okay. They can get to the ostium and they can cause an infection. Okay. So here's one. Elevation or bone graft placement. Okay. Large perforation occurring during elevation or during bone graft insertion. Okay. And during osteotomy preparation, perforation caused by implant drill. Okay. Is it a small perforation or is it a large perforation? Okay. If it's a small perforation, approximately less than 2 millimeters, what we're going to do, gentle membrane detachment and elevation. And you can throw in a piece of PRF, okay? And check if there are any symptoms, okay, of sinusitis in that area, then the bone has gone in and blocked. If nothing, then you're good. If it's a large perforation, again, do you put in a short implant or not? Okay, if you put in a short implant, you're good. If you don't put a short implant, you can't put a short implant, then what are we going to do? We're going to do a lateral sinus window lift.
When you say, let's say you have 10 millimeters, right? And you said that you perfect.
Yeah,
Then what's the difference? Why do you have to play a short implant? Can you go along here for the 10? Is it make a difference?
you
You're
can't,
gonna put anywhere, you're not gonna put bone graft, right?
not gonna put bone
Yeah,
graft.
you're just gonna go straight 5 by 10. Does it make a difference? Why does it have to be short? You worry about that implant going to the sinus? What's the reason behind it?
Good question. I guess you can go 5 by 10.
Yeah, because
Very
you
good
don't have-
point.
you don't have these,
Very
if
good
there is
point.
short Implant, you know, because in order, if we have 8, we might have more.
Very good point. But here's the thing.
Dr. Karami, can you repeat the question?
Okay, Dr. Andy is saying if we get a perf, why use a short implant? Since there's no repercussion for placing an implant in the sinus with a perf, nothing untowards happen. Then why put a short implant? And I think he has a very good point because earlier we were talking about a study that showed you get an implant in the sinus, no problem. We don't want to do that routinely, but even if you raise the membrane, you can put it in there without any bone, no problem. If you perf the membrane, you put it in, no problem. No infection happens in the sinus, and the implant success rate is very good as well. So yeah, we don't need to use a short. We can use an implant there. I think what would change this metric here is can we get a decent size implant that's suitable for the tooth that's going in with good initial stability. Okay, I think that's what matters. Okay, not the size of the implant. I think the initial stability is key here. Now, anything less than any ridge less than 7 millimeters, I would be very hesitant to, if I got a perf like that, I would be very hesitant to put an implant and just pray that it flies, okay? Because if I get any kind of bone loss, and if I want to place the implant subcrestal, so that leaves me just 5 millimeters. If anything happened, then I'm going to be going fishing for that implant. That's my, so if it's 7, 8 millimeters, I can live with that. But if it's 5, I'm never placing an implant in a 5 or a 6 millimeter ridge.
So let's say,
If I'm not sure I can get a good lift.
so my question is, let's say you took, right, and you say, you know what, I'm just gonna abort the surgery. Can you just close it up? Like,
Why?
with the-
Why?
Or you have to go lateral? and-
Why abort? What's
Well,
gonna
it's
happen?
just like another option besides from placing the implant, like.
What's gonna happen in 3 months from now? You think you're gonna come in and try and place the implant and you're gonna lift the membrane and it's not gonna perf? Is it gonna be any thicker?
Is that-
No, it's not going to be. As a matter of fact, it's probably gonna come back thinner. So we just go in. Okay. Think of the story. You go to the doctor, you have to take the appendix out, okay? You can only do laparoscopic surgery. You get a bleed, it explodes in there, he has to go, but he hasn't been trained. So you gotta be able to switch to lateral any minute, okay? Autopilot off, now we're flying manual. But that was a very good point you raised. And all this time I spent prepping this thing, I never even thought about that point. It's a very good point. So forget about the short implant. We're just placing an implant in the area. And I think the only metric that would have to change here is, do we have good initial stability? Okay. Okay. Implant insertion, perforation. I don't know if I caused any perforation or not. I don't really care. The only thing I don't want any of us to do is to not be sure if we cause the perf or not, and then place any bone particles in the sinus. If not sure, leave the implant without bone if you get good stability. If not sure, okay?
Membrane, you can just put the membrane. If you are not sure if you work or not, you
Yeah.
can just put the membrane
Like do a lateral approach.
with the cluster.
And how are you going to make sure, how are you going to set the membrane through a very, very tiny hole? You want to be in control, right? Okay. If you want to put the membrane, fine, but don't put bone. Unless you're in control, don't guess. Okay. You have to be in control. You have to know, I secured the membrane. I put the bone and I know it's not going to go flying in the sinus. Okay. So the crestal lift is actually an easy way, but it could turn into a lateral lift. So every time you have a crestal lift plan on the fact that it may very well turn into a lateral, okay? When you're using Versa, you can actually cause damage if you are not careful. These markings are genius, and okay? The bottom one, that black line, the very first black line, the bottom is 3, the top is 5. The thin one in the middle, which is the only thin one, is 8. Okay? The next thick one, the bottom is 10, the top is 11.5. Okay? So it's very easy while you're drilling to know, oh, this is the 8. Oh, this is the 10. Okay? This is where most of us will make the mistake. There's an additional 1 millimeter here. The very bottom. The tip of the drill is about 1 millimeter high. And it's not calculated in here. So be careful. Yeah. I don't know. Okay. Yes. You guys didn't know this, right? That's why I thought it's interesting to put the slide in there, because just in case.
Most osteotomy works have that.
Huh?
Most osteotomy works have that.
Yeah. Yeah, they all have that thing. They don't calculate it. Not calculating it is the thing that you need to know about. Okay. So I'm not going to talk about Versa again. You guys know all this. Dr. Anu, putting bone using Versa. What's our speed?
150
What's our direction?
inverse.
We have water on?
No.
Okay, good. Okay. Here's the slide. If you guys want to go to Versa, they have training. They have online too. You can go online, you can set up an account, and you can set up an account and you can buy online,
What did your first, the bird got dough, you send it back to them? Recycle?
Heck no.
After, 40 minutes.
That's what they're counting on.
You throw it away.
You just keep buying them.
No, you sharpen. You sharpen the art.
Where's the sharpener?
Henry, are you talking about Versa or another bird? you don't have to worry about a dough because they go to reverse, right? So they're not cutting.
We get down
No, you do.
It does get
You
down.
do forward and reverse.
We
You
get
don't
down.
put it in the small one, but when you do the bigger one.
The ones that you have to get the most from are the smallest ones, because I'm usually using them for in reverse. And then the few times I use them forward is very low. Okay. Guys, I have very good news for you. We are approaching 700. Okay, so all right.
60%.
So far, have I overloaded you with information? Okay. Have I said anything that you didn't know before?
Yeah.
Yeah. Yeah, really? How you know all this? Okay. Okay. So this is what you're talking about, Dr. Shaw, putting a membrane. Okay, but they're not putting an implant though. Okay. Okay. Let me move to I want to drive home a point. And I think it's a very interesting case. Okay. And then we're going to go to myths and realities about sinus lifts, things that you heard through grandma, and things that you believe to be true, and what things actually are. But please do your assessment using a CT. I don't care if you did Pano, FMX, okay, you took x-rays from top, bottom, sides. The CT study, okay, when you don't study your CT, you're going to miss anatomy. Your evaluation is going to be lacking. But I really want to jump quickly to this case study right here. It's a pretty young lady in the prime of her life, missing a lateral. Okay. And looking at the tissues here, good thick keratinized tissue, stippled, right? The thickness of the bone, the buccolingual seems fine. I'm looking at the panel, like nice, high, rich. This looks like a good case, right? Let's take a CT. What's happening here around the canine? You see this radiolucency around the canine? Okay. Look at that. Look at that. See the size of the radiolucency? This was a lesion. Okay. And planning the implant in the area is going to be right in the path of that lesion. Okay. God knows what's in there, but can you assure full bone healing in the area? So ended up the opening area, taking out the lesion, cleaning it, putting bone graft, and then placing an implant, and then here we are. It could have been very easily missed, okay? Very easily missed, but this was a big deal, okay? This was a big deal.
And there was no brain.
No, the tooth was, yeah, it's fine, okay? Seen this before, antimicrobial classes. preoperative preparation. These are things that all can cause some kind of complications, okay? Lack of CT study, not preparing the patient, not giving them antimicrobials ahead of time. All those things can cause complication, okay? Missing pathology that's in the area and all that stuff. Smoking. I'm a little gutsy about it. If I can bring them to 10 a day, I'll do it. Okay. I had a patient, she's like, I haven't had teeth, she's losing bone. I really, I can't eat, I can say I'm wasting away, I'm unhappy, I can't taste food. She was really miserable. And as soon as I entered the room, you know, it hit me. And I said, okay, we're going to address the elephant in the room. How many packs of cigarettes do you smoke a day? She looked at me, she said, 3. I said, okay. I'm happy to do the all-on-4 for you if you pay me $500 a month only. Okay, that's it. And you can take your time. But I don't have money that's going to require you to cut down on your smoking. You do have the money. You're buying 3, but you're spending, you know how much? $35 a day on smoking. So that's $1,000. I said, I'll take half, you keep half, okay? And I'll do it for you. And she's like, I'm not sure I'm willing to do that. And I said, what makes you think that I'm willing to do it for you if you're not willing to help yourself? You know? And that was one of the weirdest conversations, you know? I said, I'll take $500 a month, you know, for a year, and I'll do it for you, the all-on-4. But you must quit. You must cut it down. Okay? She wouldn't. So the point is, diabetics, if they're constantly 7.5, 8, 7.5, 8, I can't help myself. I'm not going to do it. Okay? But if they're trying and they were 8 and now they're coming down, you know, like they're 7, 6, 8, 7, 1, I'll do it because he's trying. Okay? But these are the things that we have to consider while doing these cases. So smoking, if you think you're going to get them to quit, that's good. But if you can get them to keep it between 5 to 10 a day, of course, you have to go on honor system, you know. Uncontrolled diabetics, talked about that. Surgical techniques, okay, have to be nice and clean and sterile, okay? So we're working, you know, the thing, and then suction falls, reach out, come back, lean on the thing, bring the light, touch this, touch that, lean, and that stuff makes me go crazy. Okay, if you put your sterile gloves on, okay, you stay sterile. Something fell, that's okay. Don't worry about it. We'll get somebody else to pick it up. Stuff falls on the ground all the time. Don't touch anything, okay? And I keep on rinsing with antibiotics repeatedly. Whatever, I have them rinse with Paradex for 2 minutes ahead of time. We wash, we wipe their face, as you all know. We wipe their face before we start, and then we get you in sterile gowns and gloves. Stand there. Don't blow it away. Don't grab the air water syringe. Don't grab the slow suction. Okay. You know how dirty that is? I'm sorry to say, it's in the dental office. We know. The bib. Don't let me go there. I refuse to use the bib holders. I got those sticky ones because they're disposable. I'd like to do a culture just for fun of it and see what's on the handle of the slow speed suction and the air water syringe and the light handle and the bib holder. Just those 4 things. The impression gun, the composite gun. Okay. So that surgery required antibiotics before we start, right? Okay.
Antibiotic brings up the- how do you, like, order the tetracycline?
How do I order tetracycline?
No, I mean, prescription, do you put on your own?
Yeah, you
What
can
are
get the doxycycline. You can prescribe it for yourself, or a doctor that you're working with. You can prescribe it to your friend. You can prescribe it for me and give it to you, and then you keep it, and then you mix with. I buy from a pharmacy in Mexico. I call them and I can send you the email, and you can buy tetracyclines from them, doxycyclines or whatever, and they charge a flat fee for shipping. So you can order, like 200 or something. So, yeah.
My relatives can get.
Okay,
from-
yeah, you can get from India
Yeah,
too.
they don't have prescription. Yeah. You take
Okay.
your own prescription at the airport. Yeah, but we have. really got
Where? Which airport? Here?
Yeah, in the.
Here?
We come, yeah. They need prescriptions. They need, my dad always comes with a prescription. Whatever medication for them.
Yeah.
Because they get like 6 months of medication, so they're like, why are you carrying so many? So they need to.
Operator experience. Okay, that's why you're here. That's why we're doing this, so you can gain the experience. You have somebody next to you, you're working next to somebody, and you have somebody else with you, and don't worry about speed. We talked about that, okay? But it's one of the things that could affect the outcome of a sinus lift. Okay. We are to 779, and I'm going to run through this, okay? Would you guys like a little break or?
No.
Okay, we're gonna go through this, huh? Okay. I want to talk about quick myths and realities. You guys all know this, okay? All sinuses are created equal. Sinus grafting can cause sinus pathology. Smoking does not cause sinus graft complications. CBCT presence of the intraosseous blood vessels should dictate lateral window boundaries. A positive bellows effect always indicates no sinus membrane perforation. No need to place a membrane over lateral window. Schneiderian membrane contributes to sinus bone regeneration. Traditional or crestal sinus grafting is predictable. In the presence of large membrane perforation, abort. If pathology present, abort. No need to know lateral window approach. All I need is a one-day sinus graft course. I think you all know where I'm going with this, okay? Are all sinuses created equal? No. Anatomy is different. So what do we want to examine? CT. Is it predictable? It's one of the most predictable grafting procedures in dentistry. So no reason to be afraid of it, okay? Okay. It's very, very high predictability. The success is very high, okay? Not all sinuses are created equal, okay? An edentulous arch is different from a free end saddle, is different from one or two, different from a single one. So your approach is going to differ, is going to be modified to match the area that you're going to graft. When do we bring out the big guns? The smaller the area, okay? Because there's not enough bone to feed the graft, so bring out the BMPs. What do we warn the patients about? Swelling and edema, okay? All right, very good. Get this book or take his course. You will benefit something, okay? I did overstuff this presentation. It's a lot. Okay, myth number one. All sinuses are created equal. Not so. Anatomical and clinical variations. Good. So we dispelled with this one. Sinus grafting can cause sinus pathology. No, that is not true. Okay. Sinus graft will not cause sinus pathology if you are doing everything properly. Okay. But if a patient has a history of chronic sinusitis, these are the ones that are prone to have post-operative sinusitis. Is that clear? So doing the sinus surgery does not cause sinusitis. But if they have history of chronic sinusitis, okay, then they have the predisposition for it. Okay. Smoking does not cause sinus graft complication. Yes, it does. Okay. All right. CBCT, we're going to do presence of an intraosseous blood vessel should dictate lateral window boundaries. Dr. Vahid, by the way, I used to be exactly like you. I'm gonna look at that. I'm gonna look for that round thing. You know, when I see it, up can do lateral. But right now, it's okay. You can cut. You can coagulate the artery, and you can proceed. There's plenty of blood in the sinus. We're going to face it 20% of the time. Okay. Anastomosis from the infraorbital, posterior superior, sphenopalatine, okay, posterior septal, you name it. Lots of blood. 20% of the time, we're going to face some kind of bleeding. So let's deal with it and let it not dictate what we do. How we deal with it? Elman. Okay.
No, the other, if you don't have the other one, then pressure.
You can do pressure. You can ligate it too sometimes if you can see it and you're not freaked out. Okay. But if it's in the bone, it's hard to stop. All you see is like you're in the bone and you're like psst, 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 doing that. Okay. So you take your hemostat and you kind of crush it and you leave it there for 5 minutes and it will be fine. So presence of an intraosseous blood vessel should not dictate lateral window outline. All this is done via studies. Positive bellows effect indicates no sinus membrane perforation. Just the fact that I put it in this section, you know that it's not true. You tell the patient, okay, take a breath. Oh, I see the membrane going up and down. No perfs. BS. It will still go up and down. Okay. Not with a big perf. I mean, if you can see it, the only reason why you're asking the patient to do that is because you're suspecting, okay, but you can't see it. So you say, do that, and then you see this. It's like, oh, thank God, good, you know? No. So we treat, so bellows effect can be positive in presence of a perforation. And we treat every sinus elevation as if we're going to do perf treatment. Okay. Very good. Okay. No need to place a membrane over lateral window. No. Why? 100% of the cases, what happens? You get the expansion. Very good. Very good. Very good. And I'm repeating the study here again. Okay. Membrane with fixation necessary to prevent graft migration and soft tissue invagination. Okay. Schneiderian membrane contributes to sinus bone regeneration. A study says may, but in fact, it won't. And what are we going to do? We're going to cover it with membrane. We don't want it in the area. We don't care about it. Okay, we're not dealing with that. So again, remember our osteoblasts are very small. So the more bone we expose, the better it is. So nope, it plays a very minor role. Traditional crestal sinus lift is predictable. Can I get a, it's not. It's a blind procedure. So sometimes we put the camera and we're looking in and we don't see black, we see the reflection. But still, what happens after you put the bone? Can you guarantee that there's no perf? What happens after you put the implant? Can you guarantee there's no perf? You can't. But when you put the membrane there yourself, do you care if there's a perf? Okay, so that's another myth that we're going to dispel with Miyambe. I like it. Okay, traditional approach is a blind procedure resulting in membrane perforation and associated complications unbeknownst to the clinician. We may not know that the bone blew through it. Okay. In the presence of large membrane perforation, it is best to abort procedure and return X months later after the membrane has reepithelialized. Guilty. I've been doing it up until last year. I've been doing that. Oh, we gotta stop. We gotta stop. Dr. Lee and I did a case last year. Remember? Yeah. Yeah.
How did it, what was the result, Dr. Harmy? Was
with
it
Dr. Lee,
successful?
last month, Dr. Lee put the graft in. So finally. But we could what we should have done is we should have placed the membrane and proceeded with our grafting back then, a year ago. So I'm changing my ways. I keep on learning. I keep on changing my ways. So you get
Is that the one that I I screwed up with the piers?
that's the one. We could have just proceeded.
Oh my God, it was so big. I don't know. I would be scared putting anything in that.
All right. Whatever method is chosen, okay? If the rent is too large, the sinus graft procedure should be aborted until the membrane has had the opportunity to be re-epithelialized. No need to abort. Instead, use the PICOS sinus membrane repair technique. The pictures that we've been looking at over and over and over today. Hang on, guys, we're almost there. If pathology is present, then abort the graft and re-enter X months later. No, if we have slight thickening of the membrane, if we have a polyp, if we have a mucus retention cyst, proceed, open, pierce the membrane, take the pathology out, do the PICOS membrane repair, and proceed. Don't let it stop you. Okay. Repair technique. PICOS repair technique. Okay. No need to know lateral window approach. Okay, I'm not even gonna talk about that. It's okay. Okay. All I need is a 1-day sinus graft course. Okay. I don't need to talk about it. But here's a typical sinus graft course. I've been to one. A few. 8:30 registration and sign in, right? And then by if you're lucky, you get a 2-day course, okay? And then they have a model. I remember practicing sinus lifts on a model. I'm like, how is that even close to because I did that in my residency and I knew, and I did it with the oral surgery, I knew the membrane wasn't that thick, so no. No. You want to do full day, you want to do a lot of cases, and you want to get a mentor, and you want to bring cases, you want to work with somebody that you trust. Okay, pair up. Okay. Hey, Dr. Yu, can we do this case together? Okay, Dr. Kazim, Dr. Key, whoever. I have a case coming up. Can we do it together? Okay. There's comfort in numbers, especially if you both do it together, you help each other out. You sacrifice some time here, they sacrifice sometimes there until you're both over the hump, but you need to get it done. Now, for the most exciting part of the lecture today, which is almost done, armamentarium. what you need, where to get it, how much it will cost. Okay? If you're going to get a piezo, try Net 32. They have a piezo for $3,300. I have the photo. There it is. That's what it looks like. Okay. And it comes with tips, fiber optic tip. You want to spend $8,000 and get one for $8,000? Go ahead. I'd buy two for $3,500. Use one when it breaks. Use the other. You know, I had one for $8,000, but it was both a piezo and an implant motor, like the, you know, and it's still alive. It's still working. Straight handpiece. I would always recommend to get, you know, have both, but get a straight handpiece. You want to spend $2,000 on a straight handpiece, or do you want to spend $3,500 on a piezo? Okay. Let me give you a better option. Okay. Okay, these are the birds that you use. I order them from Eagle Dental. So just go on Google, do Eagle Dental. It's right there. I'll send you everything. Okay, Eagle Dental, and right, I want dental burrs. I want the surgical ones, the long surgical ones. Okay. Okay. I'm not sure if size 5 or 6 or 8 is best. Get 5 of each.
But this is a straight handpiece or is this?
This is a straight handpiece, but this is a friction type. This is a friction, not latch. Okay. Now, you don't want to spend $2,000. You can go to Avtech Dental and you can buy the straight handpiece for $200. Okay. All right. Get two. Because if one breaks, you don't want to be up a crate. If you're not spending the $2,000, spend $400.
So it's feisty.
This is slow, like your implant motor. Okay.
So you're sending us all those, right, in the PDF?
Yeah, yeah. Yes, I am. And you can get the implant handpiece. There's a type that's straight latch, and you can use the latch rounder. So whatever handpiece you buy, make sure you buy the bird that matches. If it's friction or latch. I'm just telling you, because you'll get stuck. I'll remind you. Okay. Biologics. We're really counting on your body. We're really counting on the patient's body, okay? So we're getting the membrane, we're getting some xenograft and some allograft, okay? Osseoseal. For that, you can contact Dr. Bassem, and the more we buy, the cheaper we get it, okay? The more we buy, the cheaper we get it. All right. Same thing, you can contact Dr. Bassem for this kit as well. I have this one. This is the one that we use in the program. I have this one, and I have 3 different other varieties. But this one has the tacks, has the gun for the tacks, has the screws. If you're doing tenting screws, it's got everything. Okay. I'm assuming this is about $2,000. Okay. But I want to tell you something. Each screw, if you buy it separately, is $35. Okay, this one comes loaded stuff, but each screw is $35. If you want to buy just the tack, I think we can get that as well. Just the tack and the gun. Okay. If you want to buy membranes, you can go here, and I'll show you one that I like a little more. I like this one more because it has that titanium reinforced mesh in there, okay? So it has the structure. Dr. Andy, I will send you this. And you will get it. Thank you for coming. It's good to see you. Okay, so you go to AD Surgical. You can buy a lot of stuff from there, but that's there. Now, my dear friend Amazon, I bought this kit from Amazon. I can't, okay. And guess how much I paid for it?
Oh, that's really good.
Okay.
In Pakistan?
Screw 7. Wherever it's made. It's from Amazon. It doesn't tell me where. But I've been using those curettes, some of them for 5 years.
They're not rusting?
No rust, no
This
discoloration,
brand is sold even like.
nothing.
See.
okay? And I just bought 3 more this year. So, and actually, have you ever heard of Vista technique? Okay, you can actually, you can do Vista using this too. The Vista stuff alone is $2,000, just the Vista stuff, and it won't do a sinus lift for you. Okay, your butterflies. Okay. $49. Remember, 21 and 23. The 23 is thinner, the 21 is thicker. Okay, you will find it on eBay. Don't forget to buy these, the holders, because you get those, you get the butterflies, but you don't get the tube holders. Get the tube holders. I bought like 500 for like $100. They're so inexpensive. Okay, there they are. And they have them in sets where they would have the holder and the needle together. Okay, tubes. You're gonna get the tubes, the red tubes, the red top. See, this is what you want. You want the vacuum blood collection tube, clot activator. These ones, rubber red top. These are the ones you want. Get 100. Don't get more because they have an expiration date. Okay. Now, the yellow ones that we use for the CGF, they're a lot harder to find. They're becoming harder and harder to find. But I found them on 4MD Medical. And it's 100 tubes for $151. Okay. And when you run it through the machine, the blood doesn't clot. Excuse me. All right. My favorite guy. Okay, my favorite guy, transilluminator, vein finder, Dr. Vahid. I use this to find veins from day one. I can't find, I'm not a phlebotomist. I don't have that skill. I have not developed it. I mean, if the vein is jumping up at me, I can see it, okay. Other than that, I always use the vein finder. It makes life easy. You will find many other configurations. My experience, this is the best because this one opens and closes. And you open it a little, it allows you to put the needle in. And then it pushes down and it actually holds the vein. Sometimes the vein will run sideways from you. This one holds the vein. There's one that has a round head. I don't like it. This one beats it, hands down. I bought 4 or 5 of these, okay? Every time I buy one, I buy one just like that one, okay? It's a bit expensive, but the very first one I bought is still alive, right? I had it for many, many years. Don't forget to buy tourniquet, okay? And finally, we're going to buy the centrifuge. You can spend $4,000 or $400. This one, it will actually tell you PRP, PRF, CGF. You just adjust it, put it, done. And the only 2 we used are the PRF and the CGF. Okay, this way you've got your setup.
Should we buy 2?
I buy 2 because we're 5 chairs running, but for one office, and if you get it from Amazon, you get it quickly. You know, it arrives fairly quickly. Now here's the Elman unit. Whenever you buy the Elman unit, make sure they have the tweezers attachment, because that's what you're going to use if you get an artery bleeder. You're going to hold it in between the tweezers, connect it to the unit, of course, and it's going to coagulate. Okay, and it's got to have a bowl. If it's in the bone, and the blood is just squirting out. You take the ball one, it's a large, and it goes on it, and it makes the bleed stop. Okay, so a brand new one, Shine and Patterson, they're off their rockers. They're like $12,000, $11,000. Okay,
Now you know what it's for. Now you
Huh?
know what it's for.
Yeah.
Exactly, now I
Yeah.
know what it is.
it's a very, very it's a very, very good, very, very good machine to get. Okay, I thank you, and you ought to thank yourselves. I applaud, admire your ambition, dedication, and tenacity to sit through it, and wish you all the success you can attain. Hopefully, your sinus lifts are great, and you continue to grow in your professional journey. Thank you. Thank you.
It's like together.